We're thrilled you have joined the Treatment and Recovery Resource Meeting. This meeting is a product of the Treatment and Recovery Committee for the Governor's Alabama Opioid Overdose and Addiction Council. These virtual calls are designed to provide valuable insights, resources, and support for professionals involved in helping someone gain access to treatment and recovery resources. Each meeting will feature 3 dynamic speakers representing different organizations who will share the resources they have available to support our important work in the field of treatment and recovery. These meetings will occur on the first and third Wednesday of every month at 12 p.m. So please continue to join us as they occur throughout the year and feature new agencies with each meeting. The Zoom link will remain the same for every meeting this calendar year. Each agency will have 15 minutes to share about services and referrals, followed by 5 minutes for any questions our attendees may have. We ask all participants to remain muted during the presentations. When we open for questions and answers, you can unmute to ask your question, or you may type it in the chat and we will ask it for you. Without further delay, I'm excited to introduce the 3 agencies for today: our Kolbe Clinic, Akron, and Recovery Resource Center. So we will begin with the Kolbe Clinic.
Hey guys, give me 1 sec. I'm starting up this presentation here. All right, guys, can you all see the slideshow?
Yes.
All right, guys. So just as a quick overview, Kolbe Health Services is actually a group of 2 companies, Kolbe Detox, Kolbe Clinic. We're going to talk about Kolbe Clinic today. I get this question all the time. Where does Kolbe get its name from? Kolbe comes from Maximilian Kolbe, who is the patron saint of addiction. He was a Polish priest who took the place of a prisoner in Auschwitz during World War II. That's how we got our name. It's from Maximilian Kolbe. All right, so what do? Kolbe Clinic is the outpatient division of Kolbe Health Services. We do outpatient substance use disorder, outpatient psychiatry, and outpatient counseling. For our substance use disorder treatment, we are Alabama Department of Mental Health certified for level 1. We provide counseling, peer services, medication-assisted treatment, and we have multiple boarded addiction specialists on staff, different physicians at different locations, and they are kind of responsible for setting our program as far as clinical guidelines that we utilize for medications. We do abstinence-based programs, we do medication-assisted treatment, we do just counseling, all kinds of different things. So anything comprehensive for substance use disorder on the outpatient side. We also provide psychiatric care, assessment, telepsych, counseling, telecounseling, and also we're launching a ketamine program mainly for PTSD, but for other mental health issues as well. Dr. Brent Boyette is heading up that new program for us, and it is more than likely going to be in 2 of our locations to start with, and then expand beyond that. So where are we? Where are we located? We are in Birmingham, Jasper, Tuscaloosa, Chelsea, Tallahassee, and outside of Alabama, we're in Navarre, Florida as well. And in the next 18 months or so, we currently have strategic plans to open in Coleman, Scottsboro, and Gadsden. So those are the next locations that are opening. After that, we'll probably start focusing further south. This is just kind of a quick overview of our administrative and leadership team, who we have on staff. I'm the CEO. My name's William Wayne Scott. The day-to-day operations are really run by Stephanie Field. She's the assistant executive director under Mickey Trim, PhD. He's the executive director. Our clinical director for our level 1 substance use disorder program is Shayla Waters. And then head of psychiatry is Dr. Daniel Major. Our addiction specialist, one of our addiction specialists, Dr. Robert Ruth, is head of the substance use program. And then Javier Davis, who is a psychiatric nurse practitioner, she kind of heads up all of our other day-to-day clinical oversight for other nurses, nurse practitioners, techs, other folks we have on staff. And then Pam Butler, I'm sure most folks know who Pam is. She is with Kolbe. She does some outreach stuff for us and also peer services. She kind of helps us direct all of our peer service stuff that we do. All right. So one cool thing that we have that a lot of people have not seen or heard of before is that we use registered therapy dogs in our groups. And this is Jack and this is Ruby. I just always like to show them because they're always a big hit with the patients. We take them to hospitals, psychiatric units. We take them to hospital detox units. We take them to conferences. They work in our peer groups. They work in our counseling groups. To break through with a patient, it's amazing what dogs can do compared to people as far as helping. So we love to utilize those. It's really effective. Other services that we do, things that people don't really see behind the scenes. We provide clinical coverage for substance use disorder and psychiatric services in rural health clinics and FQHCs around the state. Also consulting services to help them set up programs that are evidence-based and best practice. We provide clinical coverage for hospital detoxes, hospital psychiatric units. We provide a lot of clinical coverage for MAT for providers that may have access to SOAR funds but don't have the capacity to provide direct care. Doctors are expensive. Sometimes they prefer to outsource that. So we have the capacity to do that pretty much anywhere in the state, and we currently do it with multiple different providers. Another really cool one that we do is we have started providing primary care coverage via telehealth for some of the department certified inpatient facilities. To meet department standards, they have to make sure that patients have doctor's orders that match their prescriptions and make sure they have active prescriptions. So, that can be a real barrier for a lot of folks because of access and financial issues. And plus, they're in crisis. They really need in as quickly as possible. We can provide telehealth services to be able to go ahead and have a provider see them, get a prescription for them, obviously non-controlled, but get a prescription for them that can match their note with the prescription so we can go ahead and get them admitted. So we provide that statewide, and that's been helpful for a lot of providers that are utilizing us for that. We do some management and administrative services. Dr. Trim, he's a PhD in healthcare administration, and he has a long history of consulting throughout the state. So we do a lot to help other providers. For us, the big deal is we want everybody to be providing the highest quality of care possible. It's not a competition. We're a for-profit, but we're not out there trying to figure out how we can beat out somebody else. We're out there trying to figure out how we can cooperate and help others provide the best quality care everywhere in the state. So anyone that needs our help from that, please reach out. It's, we're happy to help in any way we can. All right, last thing. This is just kind of an overview of some of the grant work and partners that we have throughout the state that either we have direct relationships with, we've directly funded or have directly funded us, or other relationships through some of our grants. We have over $3 million in funding currently through HRSA for 11 counties in the state. There's 4 counties in the northern part of the state, 7 counties further south. There's several different grants, but basically it's treatment, prevention, recovery, and really focusing on social determinants of health within those counties. And so these are some of our partners that we've partnered with on those grants: UAB, Vital, Rural Addiction Prevention. Rural Addiction Prevention handles a lot of our prevention services and recovery services. They are statewide. They're relatively new, but they're doing really good work. And of course, the peer organizations that we love. Alabama AHEC, which is, trying to help drive professionals into those needed professions within the rural communities. And then we have some community hospitals, community hospital in Tallahassee and Crenshaw Community Hospital, both of them. We work in their rural health clinics. Contact information, if anybody needs to reach out to us, I'm going to make sure and share this presentation in the chat so you guys can take it straight from this. This last link that's on here, this is our referral link. So if anybody needs to refer a patient to us, you can actually just click that link and it asks for specific patient clinical information. And when you click submit, it comes straight to our intake coordinators that can get with our inpatient, outpatient, it doesn't matter, whatever the need is, we can help with that. info@kolbeclinic.com, and I'm going to type my contact information in the chat as well. So if anybody needs to reach out to me, please don't hesitate. I'm happy to help however I can. All right. There we go. I think I stopped sharing. So does anybody have any questions for me?
And remember, if you don't want to unmute, you are also able to type those questions in the chat. All right, the last call for questions for Mr. William Wainscott with the Kolbe Clinic.
All right, guys, this is my cell number in here too. So obviously that's just for other providers. Don't be handling my cell phone number out to others if you don't mind.
Perfect. Thank you so much for sharing.
Absolutely. Thank y'all for the time.
Yeah, thank you.
All right, so we're going to move on to Akram.
Good afternoon, everybody. Akram, I'm just a representative of Akram. I am on the board and on the certification committee for Akram. We wanted to share with everybody kind of what we are, who we represent, and how you can utilize Akram resources and refer to Akram associate members and certified members with confidence. Akram, it stands for the Association of Christian Recovery Ministries. It was started somewhere around 2010. We are a collaboration and a collective of several different faith-based recovery services throughout the state of Alabama. We do have a member in the Panhandle, Florida, also one in West Virginia, but today we're going to specifically talk about the members in Alabama. While Akram does not tell anybody how to run their program, there are certain expectations. Even to be an associate member, you have to have, a good reputation. You cannot have a bunch of people having legitimate concerns about your program. And then once you become an associate member, then we talk to you about becoming a certified member and what that process looks like. The certification process was created for internal accountability, but external referral confidence, like we said. Again, we represent over almost 50 organizations right now as it stands today. The certification process is over 200 standards, 200 standards and substandards that cover an array of different things that would make any and every participating organization better at what they do. And again, this is to hold themselves to a certain level of accountability. And we're happy to share any of those certifications with you. And we'll cover just a few today, just so you can kind of get an idea for what those certifications look like. Also, again, we come together in this collaborative association to make each other better. We want to learn from each other. We want to teach each other. So we do this through not only quarterly membership meetings where we go over what we need to discuss within the membership and recognize new members. But we also do quarterly trainings for all in-person quarterly trainings for all support staff. This is your client reps, your counselors, your intake directors, your program managers, program directors, anybody, even the people that work in your food services, anyone that has direct contact with your participants or clients. I use the word participants because that's kind of the name for people inside our services or inside our programs. But again, we also cover about 20 counties throughout the state. So no matter what part of the state you're in, there will be an ACRA member somewhere close by. ACRA members in the collective of ACRA members represents almost 5,000 beds in the state of Alabama. That is a huge number of available resources for your clients if they choose to want to pursue the faith-based pathway. And really, if you do the math and do the calculations of the length of a program, because several programs are 90 days or 6 months. If you do the calculations on the length of the program over each one of those beds, we're talking about over 16,000 beds per year. And if we all like options, right? We all like to know what's available. We all like to know, hey, um, if there's who do I call if I need a bed, or who can I almost be certain has some type of availability. And while one ACRA member may not, someone inside of our association may have a bed. We are currently, the idea was approached to us the other day, and we're going to start working on that at our next board meeting next week. A list, bed availability list specifically for ACRA members. ACRA members, we believe that treatment and recovery work better together. We believe that it takes all of us working together, pulling in the same direction, and because while somebody might enter their recovery journey at a certain level of care, and then they're going to a lower level, and then there's no bed availability in the lower level of care. Well, we want to come alongside those people and fill that gap, because we also have we've noticed and have been able to respond to a need, and that transitional housing, that aftercare, that second step in somebody's recovery journey, which seems to be the step that a lot of people get off track and return to use. There are a lot of those type of services available through ACRA members. We believe that the client or the participant, whatever you call them, is the most important decision maker in their recovery journey. If you're a peer, then you know that a client-centered decision-making process is what is the route you need to take, and whatever they say they're trying to pursue, you need to help them facilitate that with the facts about all the different pathways, including faith-based, MATs, whatever pathway it is that they're choosing. Uh, I will also address, like, one thing we always say is have the conversation. Well, they can't take such and such there, or they do such and such. That's what you've heard. And that may be when it comes to medications, certain mental health medications. And it's not that these facilities are against the medications. A lot of them just don't have the scope of services or the certain clinical staff members that it takes to execute having those medications on their property. I can speak for my facility specifically here at Restoration Springs. We are transitional housing for men, and they cannot have Suboxone, but they can take Sublocade, because it's a lot harder, almost impossible, to divert that medication. And while we don't have the staff on property to have the daily doses on our property, you can take the once a month shot. And I just use that as an example of have those conversations. If there's a specific medication, you're having problems getting a participant, finding a location for them in the faith base, call Akron directly or a representative of Akron, because we are all volunteers. There's no staff members. We have an executive administrator, which is on the call, was on the call, Joseph McGahee from the Love Lady, or any of our board members. One thing I wanted to touch on is the services available through our collective, our collaboration association, because a lot of these pieces on the clinical side of things, there's just not enough time in the day to do everything. So, like, for example, employment readiness and Hope Inspired Ministries that is used at somewhere like the Foundry, or Work Faith that is used at somewhere like the Love Lady. These are programs that help their participants learn a lot more about how to dress for an interview, how to act at an interview, how to do a resume, how to talk about gaps in your work history. They cover all these things. So if you got a participant that or a client that keeps showing up at your door, and you've identified that work uh, piece as being the biggest barrier, then you can say, hey, I know some programs that if you're open to a faith-based pathway that really addresses this specific need in your life. We also, even though we are not clinical, we do build relationships and give access to clinical, medical, and mental health care for most facilities do this. Again, that's part of just having that conversation. I know the last place I worked, we actually had UAB School of Nursing do a clinic at our facility and house their own dispensary at our facility. Also giving access to clinical mental health care, pastoral counseling, educational resources through GED programs and other programs like, for instance, linking somebody up with Voc Rehab so they can get uh, their college paid for. And then obviously access to case management through program managers and clients reps to help them navigate the legal system, help them navigate their medical health care, their mental health care, their emotional health care. And I'm gonna get through this boring part real quick. All the different or just some of the different things that that ACRM members have to go through VA certified ACRM member, is multiple different things that have to do with our board of directors, insurances. This is a big one, the grievance reporting process or procedure, because advocacy matters. Facility safety, transportation safety, participant safety, food services, even hiring best practices when hiring employees, confidentiality, legal assistance, medication protocols and storage. And the list goes on and on with professional development, client data, anything you can think of that would make a program better. There are a standard to be a certified member of ACRM in there. And all too often we've found that most programs, faith-based, clinical, fill in the blank, are often known too much by a misrepresentation of their program. Somebody that has been disgruntled with them, somebody that went and filled out that Yelp review or that Google review, because those people that often take the time to do that are mad about something. So again, if you hear something, call the facility and ask them, call us and ask them. And I always love to use this example. There was one ACRA member who a city council got a phone call and said, hey, those ladies over there are throwing cats off the roof. And so the city council called him, and he's like, what is going on? Why are y'all throwing cats off the roof? And it come to find out they were throwing food down to kittens off. So they were throwing the food to the cats off the roof and not actual cats off the roof. So just a prime example of how something can get twisted. Somebody can make something up. Somebody just doesn't have all the facts. And we don't want to be known by that. We know there are predatory ministries out there, and I'll use ministries very loosely. But there are predatory facilities that have nothing to do with the faith-based pathway. So we just want you to learn about ACRM so that you can refer with confidence, know who we are, what we stand for, the level of standards that we hold ourselves to, so that you can refer with confidence. Thank you. Any questions?
Judd, I have one.
Okay.
So help me understand, if you are an Akron member, does that mean that y'all have a common contact point to find beds for patients that need beds? In other words, do we still have to call each individual facility that's certified trying to locate a bed, or is there a common contact for, say, one of my social workers that is looking for placement for, because that's a common problem we run into, is building the network of referral sources that we have to send patients in the first place. My folks struggle with it all the time.
Yep. So great question. I just put our website on the chat. Now, all the website will do will help you identify the facilities that are under the Akron umbrella, and it will give you their best contact number and let you know if it is a male facility, female facility, if it houses children as well. But again, like I said earlier, we are working on that bed availability list specifically for Akron members that I believe will probably be housed on the website, because that's the best way. So that is coming soon. But you can, if you ever hit any obstacles or barriers in this, you can always contact myself or Joseph, and we'll help you along the way. Because
You be careful saying that. You'll have my social workers beating your door down.
I'm totally fine with that. Joseph, I don't know. He may not, but you know, Joseph works at the Love Lady. He already has 500 women and children under their roof. Any other questions?
Again, if you would rather not speak, you're able to put those questions in the chat. All right, last call for questions for Mr. Judd. Thank you so much for sharing. We greatly appreciate it. All right, so we will move on to our last resource for the day, and that is the Recovery Resource Center.
All right, thank you, Audra. Can everyone hear me okay?
We can.
Okay, great. I'm going to share my screen. Okay, does everybody see that? We good? Okay. So hey everybody, my name is John Bales. I am the program director at the Recovery Resource Center, and we are a program of the Crisis Center. The Crisis Center is a nonprofit that's been around in Birmingham for about 50 years. It's a United Way of Central Alabama agency, and the short story is started with suicide prevention and intervention back in the 70s with a hotline, and then started adding services over time. They have a SANE program, which is Sexual Assault Nurse Examiner, and a rape response program. They have a call line for seniors who are homebound, and also a call line for adolescents called U-Talk. And then we came around in 2018. So the origin is we were a direct response to the opioid epidemic by local health officials here in Jefferson County. So overdoses were skyrocketing everywhere, really across the country. And in 2011, there were 24. By 2014, that was 123. And this is just in Jefferson County. 2016, 202. So at the time, the Jefferson County Department of Health, the health officer was Dr. Mark Wilson. And he got together with some people, namely Beth Batchelor, who at the time was the director of the Fellowship House, along with Chris Rattan at the Alethea House, and some people at UAB and their addiction recovery program, and some people at Cooper Green, and basically providers working in the space. And they just tried to come up with some idea, some way to really get people into treatment. What we knew, and this is a pretty common statistic that we see a lot, there was really, really good treatment in the area, but people weren't accessing the treatment. So the goals, and Dr. Wilson approached the crisis center because the crisis center, when they sort of came up with this idea, the crisis center had this reputation of connecting people to resources when they were in crisis. And what we know is that when someone, and this is just common knowledge, when someone wants to reach out for help, when they finally get that courage to say they're looking for treatment or they need help, they're in a crisis in that moment. And also that window is usually pretty small. And so we've got to be able to respond in a timely manner. The goals were to increase access to treatment, to decrease overdose, and to provide recovery support, and then also promote recovery and end stigma. The methods we were going to use and that we use today, just reducing barriers in the admission process, then harm reduction training, and of course, utilizing peer support specialists. It was really important to make sure that when someone reaches out for help, they're greeted or met with someone who can say, or could say, hey, I've been there, I've done that before. I'm a person in long-term recovery myself. And what I always say is, I just wonder if things have been different, or if things would have been different if the first time I was introduced to treatment, it was court ordered, it was an outpatient program. Like, what would have happened if the very first person I talked to had been able to say, hey, I get it, you're angry, or I get it, you're scared. I was that way too. I went through this program. I'm here to sort of help you figure this part out. Maybe I would have saved my parents and friends and myself a lot of pain. Primary services, information, assessment, and referral. So that initial consultation, you can call it, with the peer, we're really just there to answer questions and really sort of find out what the person might want, as opposed to what we think they might need. We're able to talk about the different types of treatment. We're able to talk about different programs, and maybe someone is just treatment curious and they don't even want to sort of move forward with an active referral. Then we're able to talk about mutual support groups or just a lot of different things. The assessment, everyone is familiar with that. It's the Alabama Department of Mental Health Placement Assessment based on the ASAM criteria. That's just to identify the appropriate level of care. And then the referral, that's going to take in a lot of different factors. The majority of people that come to us, they are either underinsured or no insurance, but we have a lot of people that come to us with insurance as well. And the cool thing about the Recovery Resource Center, when I started working here in 2019, what we like to say is it was really made up of sort of treatment all-stars, right? So it was this idea that we had people that had worked at the Fellowship House. We had people that worked at the Foundry. We had people that worked at Bradford. So just right there, we were able to sort of represent state-based, state-funded treatment, private treatment, faith-based recovery. We're really able to talk to people about any type of recovery path or treatment. Assessment is the key a lot of times, but peers lead the way. How it works, the peers listen to the clients and share their personal recovery. That assessment determines the appropriate level of care. And sometimes people don't need the assessment. That's the other thing that's important. A lot of times people will show up and they do have Medicaid, and we are able to sort of connect them to a provider that doesn't require that assessment. We're not going to force someone to sit for an assessment just to be able to say we did that. We're going to look at what they need and try and get them help in a timely fashion. A lot of times we'll connect them with Journey or Kolbe, or so glad Kolbe has the detox unit now, or Self Recovery, or some other provider that can get them take care of that medical detox need. And then we always tell them, hey, look, we're going to be contacting you on day 3 because we figure that's when you might actually want to talk and you might be feeling a little better, and we'll try and complete that assessment for the next level of care after that. When we do complete the assessment, one thing we're able to do is sort of use the approach. If someone comes in at a 3.3 or 3.5, we're not only going to be sending it to one provider. We're going to be sending it to multiple providers so people can get on multiple waiting lists so that people can hopefully get a bed quicker. We are going to have very individualized conversations with people about particular providers, locations, demographics, things like that. And we will try and identify the best resource, but we're also going to make sure that people know all of their options and they're not feeling like they have to go to one particular place. Once we send the assessment, that's when our peer work really begins, because there is often that sort of gap. That's when we're providing regular follow-up services. We're identifying any other barriers that might get in the way. We're helping connect clients to primary care so that they can get 30 days worth of medication because a particular 3.3 might require that. We're identifying transportation. We're just anything that might pop up that could keep them from actually getting that bed when it opens up. We're trying to address that in the interim period and also make sure they remain motivated, make sure they remain willing to actually go to treatment. Outreach and community support services. We have always had a relationship with UAB's emergency department since we began. So in 2018, we started working on a SAMHSA grant with UAB Department of Emergency Medicine just to expand ED-initiated MOUD services. We've also partnered with JCDH on 2 different NACHO grants. We work with a lot of the local hospitals here. Social workers or charge nurses in the ED will reach out to us and we're able to get a peer over and actually do a bedside intake and try and provide that true warm handoff. Naloxone training and distribution. Since we opened up, we've been partnering with JCDH when it comes to that. We were actually the first people to ever host a naloxone training in the state back in 2018. Luckily, the laws have changed now and we don't have to partner with them in the same way. Used to, we had to have that public health nurse or a prescriber or a pharmacist on hand to actually hand the naloxone to them. Now, because it's over the counter, we're able to actually put naloxone in our clients' hands when they come here, and it's been a game changer. So now we're doing a lot of community-based trainings on our own. And then also we send peers to local shelters here in the Birmingham area, whether it's Firehouse or First Light or Pathways. We're always able to get a peer somewhere if they're needed. So this is a quick look at our numbers since 2018. Y'all, we drastically underestimated the need. When we did this grant, or when we wrote the first grant in 2017, we estimated that we would see 600 clients in the first 3 years. And so you can see what happened in the first 6 months. We saw over 600 in the first 6 months. You'll see a huge uptick in 2021 and 2022. That is because after COVID, we started a pilot project with Alabama Department of Mental Health. So as everyone knows, when COVID happened, telehealth became a thing. Prior to COVID, you always had to be in person to complete that assessment. You had to be in person, you had to sign for it. When COVID happened, we started providing telehealth assessments. We were allowed to use verbal consent, and we started providing assessments across the entire state. To date, we've done assessments on clients in every single county. ADMH approached us and asked us to basically serve as a pilot project for a statewide assessment center. And we were able to start really helping people. It didn't matter where they were, and it was so needed in COVID, and it's still really needed today. This shows you our the difference between, or the numbers for opioid, alcohol, and stimulant use. Like I said, we were a direct response to the opioid epidemic, but opioids have consistently kind of been in third place here. And I think that's really, really important. Obviously, now we know about the presence of fentanyl and stimulants like meth and cocaine. So stimulants, very important, but also alcohol. I feel like we need to continue to talk about alcohol and where that is sort of positioned in our society, and it's still a major issue. Referral targets. So you see the detox, residential, outpatient, MAT, and transitional. Intakes per county. Jefferson obviously is the largest part of the pie here. And that is because of the first basically 3 years of existence, we were only serving Jefferson County and the counties that were residents that were able to drive to us. So Walker County was one county that people started from day one driving from Jasper or Summerton or Carbon Hill to Birmingham to get an assessment because they did not have anywhere to get the assessment there. And in 2021, or really 2020, we were approached by some community leaders in Walker County about opening up a satellite office in Jasper. So we did that in 2021. And you'll see where it says other, like I said, that does represent every single county in the state we've been able to serve to date. This shows you some of our referral sources in the top left. You'll see hospital is a very large chunk, especially this last year. But we receive referrals from obviously other community-based organizations, but churches, corrections, and law enforcement. Basically, anyone is able to refer to us. It's a very easy thing to do. There's a breakdown for gender. And in the bottom left, you'll see that telehealth is quickly approaching our in-person. And actually, all of these numbers kind of stop at January. So I think we might, if we're not 50-50 now, we could even be doing more telehealth than we are in person. And then there's a breakdown of race. So here's some data points. Collecting data is very important to us. Our partnership with Jefferson County Department of Health, we really try and look at what we're doing through a public health lens. So we understand that data is really, that's what's going to move the needle, and that's what's going to convince people that these services need to exist and they need to be supported. 63.9% have experienced trauma, 36.9% have had a prior overdose before they even come to us, 29.4% prior suicide attempt, and 32.7% are unhoused at intake. And then 10 days right now is the average treatment wait time. And that is an average of both residential and outpatient. Here's some highlights just throughout the years. Naloxone has always been a major component of what we're trying to do here. Last year, we partnered on 46 trainings and helped dispense more than 1,100 kits. Education, we've contributed to UAB on a couple different e-learning modules for healthcare providers. We partner with the Fellowship House and Walker Women's Clinic in Jasper on an initiative called She Recovers. UAB is also a partner there, and that's really, it's a program geared towards pregnant and parenting women in the Walker County area that connects them to an outpatient program ran by the Fellowship House. Collaboration, that's what we do, y'all. I mean, I always tell the story. The RRC, we didn't come up with the idea for the RRC. It wasn't like a bunch of people sat around and said, let's come up with a way to do this and call it the Recovery Resource Center. What it was a bunch of you who were operating in this space, working in this space, sitting around saying, what do we need? And we're here for the clients, obviously, but we're really here for the providers. We're here for the referral sources. We're here for the people in the community that are providing really good treatment, but you just need help getting people to you. And expansion, that sort of mentions the things I talked about as far as the Jasper location. been open since August of 2021, and the pilot project that resulted in us kind of really growing and doubling our staff back in 2021. So this last slide, I tell the story. This graphic you see, it says, "Thank you for loving us. Even when we don't love ourselves, I would not have gotten help without you." So in our office here in Birmingham, we have a conference room. We also have a couple consult rooms. And a lot of times the consult rooms are being used, and a peer has to take a client into the conference room and do the intake there. And this was in 2019. The peer got up, took the client back to the waiting room, connected them to the assessor, and realized that they had left some paperwork in the conference room. And when they went back into the conference room, the client had written this on our whiteboard with the marker. And so it's still there today. We're getting ready to move offices. There's going to be a new Cooper Green Mercy here in downtown Birmingham. We're going to be moving over there in a few months. And I'm really trying to figure out a way, like, how can we shellac this or preserve this and take the whiteboard with us? Because if there's one sort of sentiment that sums up what the Recovery Resource Center is trying to do, that's it. So I mentioned the referral process. It's really simple. You can just send an email to rrcintake@crisiscenterbham.org, or you can just pick up the phone and call. That's what we always tell people to do. Call us, and we don't need much information. We just need to be able to find a way to have a way to contact the client. And then what we always try to do is keep the referral source in the loop through releases of information and things like that. We're able to really kind of make sure that we help them as much as we're helping the client too. So I think that's it. Any questions? I went through that pretty fast. Sorry.
John, this is Lisa Bright. I have a question for you.
Sure.
So we have had situations in our city where people will wander into a library or a city building, and they're looking for help from all different kinds of things, from either homelessness, but primarily going to be in the drug related world. Is the Crisis Center, we're actually sitting down and doing a book of where we can send people when that happens. So the Crisis Center would be, I think, obviously a great first start for us. Is there a particular person that we should ask for, or just is it based on what the need is?
So what I want to say is it would be based on the need, but I also want to make sure you're not confusing the Crisis Center with the JBS Crisis Care Center. So that's something that we're running into. Are you thinking of the CREG, the Crisis Care Center, the short-term stabilization?
No, I'm sorry. I'm thinking about when I Google recovery resources, it takes you to the Crisis Center website.
Okay.
So I'm looking at that website and the numbers there and the different resources there.
Yeah. So, okay. And I'm sorry about that, Lisa. It's a PR nightmare for us.
Sure.
for the last, I guess about year and a half, with the Crisis Care Center versus the Crisis Center. Yeah. I mean, the Crisis Center is able to help really in that sort of, crisis moment. The cool thing about the Crisis Center is if someone were to pick up the phone wherever they're at and call 988, they're going to get the Crisis Center. Or if they were to call the actual Crisis Center CSL crisis line. And then the Crisis Center, being a part of the United Way, has access to 211. 211 is an amazing resource everyone needs to know about. 3-digit number, pick up your phone, call 211. You can tell them anything, and they are going to connect you to the appropriate resource. But yes, what you're talking about with the libraries, we work really, really closely with Birmingham Public Library and the Homewood Library. And a lot of times that is kind of a place that people end up And you can certainly reach out and we'll try and come up with a solution.
Great. Thank you.
Oh, you're welcome.
Again, if you have a question for John, you're able to put that in the chat if you do not want to unmute and ask verbally. All right, so last call for questions for John. And also at this time, we have a couple of extra minutes. So if you have a question for William or Judd as well, we could revisit them. I'll give everybody just a second in case they have thought of something else that they would like to ask of any of the presenters today. All right. So if no one has any questions, I would just like to say thank you to the 3 organizations that came today and were willing to share their time with us to let us know a little bit about what they have to offer. Also, thank you to the participants for joining us. We hope that you were able to learn something new about a resource available to you in Alabama for treatment and recovery. So please join us again on April the 17th for our next virtual meeting, and I hope everyone has a wonderful day. Thank you again.